Good morning, everyone. So, by way of update, my PCR test was negative, but I'm still required to quarantine until Saturday. So, we're online today, but we'll be back in the saddle, that is in the classroom, on the following Monday. Of course, Friday is Good Friday. We won't have class. And we won't have class on Monday either. So week from today, we'll be back in the classroom, hopefully to stay for the rest of the semester. And that's the situation. So my daughter's infection looks like it is quite mild. So she's doing much better. And that's largely good news. I thought once my test was negative, that would mean that I could be back on campus. How wrong I was. So we had a bit of a argument, shall I say, over how long I was supposed to quarantine. It was suggested that I had to quarantine 10 days from the day of my test result. I told the powers that be that is flatly ridiculous. So we agreed on Saturday. So Saturday it is. So there we are. All right, so we're going to finish hypercholesterolemia. We'll get into coronary artery disease and angina. Then we'll talk about heart failure. And then we'll go from there into clotting and anticoagulants. That's the roadmap. Let's have a word of prayer, then let's dive in. Father, thank you for a warmer day. Thank you for sunlight. Thank you that when we get up, it's not quite as dark. Watch over us now. For those who are on quarantine, help us use our time wisely. And for those of us who aren't sick, please help us to keep from getting sick. We pray the vaccine shows a very substantial dispersal in our state. And for those who are sick on campus, help them to logistically be able to get meals and they receive the care and whatever else they need from this time. Lord, please watch over us, and thank you for Easter. Help us to celebrate the resurrection with gusto this weekend. In Jesus' name, amen. All right. We talked about statins last time, and that moved us to the bile acid resins. These bind your bile acids. They essentially sequester them. Normally, bile acids are reabsorbed. A percentage of them at least are reabsorbed and recycled. When you take a bile acid sequestrant, these grab the bile acids and they essentially get excreted in fecal material. Because they deprive the liver of bile acids, they're depriving the liver of cholesterol. Therefore, the liver upregulates the LDL receptor. You therefore get increased LDL clearance, and you lower LDL usually about 10 to 25% or so. The downsides, and this picture here shows you essentially how that works. There's 3 of these drugs: cholestyramine, cholestipol, colesevelam. Just those 3. They can increase triglyceride levels, so they're contraindicated in individuals with triglycerides that are above 400 milligrams per deciliter. They tend to cause GI distress fairly commonly. Cholesevolum is the best tolerated in this regard. They also frequently cause constipation. Therefore, you'll need to take them with other things that increase transit through the bowel. That could be things like cholase, which is docosate, sodium docosate. You can also take them with things like senna or other things that increase the contraction of the bowel. You can take them also with Miralax or something like that. These sorts of things, over-the-counter laxatives, they can be layered one on top of the other. Again, because these drugs are not systemically absorbed, they don't have systemic side effects. They do interfere with the absorption of lipid-soluble drugs. So they interfere with the absorption of tetracyclines. They interfere with the absorption of the heart medicine digoxin. Phenobarbitols, although phenobarbitols you're usually going to get if you're in the hospital, and you'll usually get them intravenously. But oral phenobarbitols, these drugs will prevent their absorption. They also prevent the absorption of warfarin. They will also prevent the absorption of fat-soluble vitamins. So if you're going to take fat-soluble vitamins, take them about 4 hours before or 2 hours after you take this medication. These drugs are available in generics. So they're usually known by their generic name. You occasionally will get them used by their trade names: Questran, Colistid, Velcol. They're used mainly for people who don't tolerate statins well. They can be combined with statins. So as you see here, take other meds hour before, 4 to 6 hours after. Mix them with liquid. Do not mix them with grapefruit juice. You need to drink plenty of water with these because of the tendency to cause constipation. And if your patient has hemorrhoids, those hemorrhoids will be made worse due to the constipation. That kind of goes without saying. Those are your bile acid resins. Fibrates are an interesting group of drugs. These activate a transcription factor called PPAR alpha, peroxisome proliferator activation receptor alpha. That's why we call it PPAR alpha. Peroxisome proliferator activator receptor alpha is just cruel and unusual punishment. We're going to call that PPAR alpha. What is PPAR alpha? PPAR alpha controls the expression of genes involved with the breakdown of fat and also with the metabolism of cholesterol and also with the metabolism of endothelial cells. So these are used if you have high VLDL or if you have low HDL, because they will also raise HDL, albeit they'll raise HDL modestly. These drugs are oral. There are 2 drugs. In this group, there's fenofibrate and gemfibrozil. They tend to cause GI disturbances. They can cause gallstones and hepatitis. They're contraindicated in severe renal and hepatic disease. They lower triglycerides substantially. Therefore, these will be used more often in people with high triglycerides. The lower triglycerides, 40 to 60%. The lower LDL, 10 to 20%. They'll raise HDL, 10 to 20%. Gemfibrozil is the only one in clinical studies that has been shown to decrease cardiovascular agents. Fenofibrate is actually probably more effective than gemfibrozil, but there's simply no clinical evidence that it decreases cardiovascular events. Clofibrate is not made anymore. So while there's clofibrate still kicking around in pharmacies, it's just not being made. So its availability is starting to decrease. If you use these drugs with statins, you'll have increased risk of rhabdomyolysis. Gemfibrozil can cause rhabdomyolysis, so you want to watch that in people who take gemfibrozil. These proteins strongly bind other serum proteins. They interact with warfarin. You'll have an increased risk of bleeding with warfarin. If you take a anti-diabetic drug called a sulfonylurea, these will raise the concentration of sulfonylureas, therefore increasing hypoglycemia. And they raise statin concentrations. That's why if you use them with a statin, you'll have increased risk of rhabdomyolysis. And here's how they work. These are the targets of PPAR alpha. So they increase expression of ApoA1, so you get increased synthesis of HDL. That's why they raise plasma HDL. They decrease the synthesis of components of LDL. You have increased VLDL clearance. You have decreased fatty acid degradation. Because you have decreased fatty acid degradation, you won't make as many VLDLs. And because you have decreased VLDL secretion, you'll have decreased LDL as well. You have decreased plasma triglycerides and increased HDL, and that's how the fibrates work.
Can you explain how it increases risk of rhabdo a little bit more? That doesn't
Sure.
really
So statins are excreted by means of a organic anion transport protein, and fibrates inhibit that organic anion transport protein. So because statins are a substrate of that transporter, fibrates inhibit a way your body uses to get rid of statins. So statin levels increase. Fibrates also inhibit statin glucuronidation. So that's a phase 2 reaction. They inhibit phase 2 disposal of statins. So they inhibit statin secretion into the kidney. They inhibit statin glucuronidation. Therefore, they raise statin concentrations in the bloodstream. Therefore, they increase the risk of rhabdomyolysis. That help?
Yeah, that makes sense.
Good. All right, so the biggie here is GI issues and gallstones. CNS effects have been reported, but they're very rare. I wouldn't make that a big deal. Some people get depressed on the drug. It's difficult to know if the drug has anything to do with the CNS effects. It's because it's rare. So that one, might want to put a question mark next to. You have increased bleeding. That's why you get interactions with warfarin. And then musculoskeletal, especially if you combine them with statins. Niacin interferes with triglyceride synthesis. Excuse me. I'm not going to let that happen again. And the way it does this is very interesting. Niacin actually has several modes of action on several different cell types. But you get increased HDL with niacin. That's really where it makes its largest contribution. You decrease triglycerides. You decrease triglyceride release from adipocytes. Because you have fewer triglycerides circulating in the body, you have less VLDL production, and therefore you lower LDL. And then it interferes with triglyceride synthesis and increases lipoprotein lipase activity, thus increasing chylomicron and VLDL catabolism. So it works in adipose tissue. You inhibit, you have a niacin receptor. So this is going to inhibit the hormone sensitive lipase that we see here. Therefore, you get fewer free fatty acids released. Because you have fewer free fatty acids released, and you have decreased triglyceride synthesis in the liver, you're going to have lower amounts of fat, so you have decreased VLDL production that leads to decreased LDL. And then niacin is also going to increase the half-life of HDL. So you have more cholesterol delivery, therefore, to the liver via reverse cholesterol transport because you have more HDL. That's going to guarantee you have more cholesterol removal. And you'll have less cholesterol delivery because of that. So there's multiple cell types that are targets for niacin: adipose tissue, liver, and then cells that also make HDL, liver, and small intestine. Niacin will raise HDL anywhere from 10 to 30%. Lowers HDL pretty modestly, about 10 to 20%. It can also lower triglycerides. In some people up to 30%, in some people up to 80%. Niacin can cause GI disturbance. This doesn't tend to be extensive, but it can exacerbate peptic ulcers. Because when you take it, you have to take about 1 gram of this stuff a day. The most common side effect is flushing. You turn beet red and you start to get warm. And that can also cause itching, so pruritus. Now, if you take an aspirin 30 minutes before you take the niacin, you can alleviate that flushing. Also, there are prescription forms of niacin that are non-flush niacin. So Niaspan would be one. And there's another, I think. It will, however, increase serum glucose levels. So you want to avoid this or use with caution in diabetics. And it increases serum uric acid levels. So it can cause gout or exacerbate gout or just cause hyperuricemia. There used to be a statin niacin combination. The FDA has withdrawn its support for it. So the company now has stopped making it. And let's see, the combination was called, oh gracious, I can't find it. It's not even listed. Yeah, it's not even listed on the medical letters table here because they're not making it anymore. So clinical studies simply failed to show that adding niacin really helped at all. So that's been withdrawn. You can use it with statins, but only do so if directed by a physician. Don't use with alcohol. You can have increased risk of liver damage. And don't use over-the-counter niacin. Over-the-counter niacin has been linked to liver damage. Use prescription niacin only. So for you to do something like this, OTC niacin, we'll just say OTC like this, and we'll put a line through it because that's been linked to liver damage. Ezetimibe. Ezetimibe, which was marketed under the trade name Zetia, but ezetimibe is now in a generic. And the generic is pretty inexpensive. This will help with dietary cholesterol. So in the small intestine, you have this protein called the Niemann-Pickman type C-like protein 1, or NPC-like 1. That's the cholesterol absorbing protein in your small intestinal cells. Ezetimibe binds to this transporter and inhibits it. So it will prevent the absorption of cholesterol by the GI tract. Therefore, it will decrease dietary cholesterol only. Dietary cholesterol only. And this shows essentially how it works. You decrease chylomicron production, you decrease cholesterol delivery to the liver, you therefore upregulate LDL receptors, you increase LDL clearance, and this will drop LDL by itself, usually on the order of about 20%. This drug can be used as a monotherapy or with a statin. It comes combined with simvastatin in a product known as Vytorin. This drug is usually very well tolerated. In some people, it can cause diarrhea. There are some reports of joint pain in people who take it long-term. Hepatitis and pancreatitis have been reported, but they're rare, and it's hard to know if those are actually linked to the drug. Rhabdomyolysis has been reported, but that's usually been reported in people who take it if combined with a statin. Bile acids will decrease the absorption of ezetimibe. Ezetimibe also will increase the anticoagulant activity of warfarin. Concurrent use with the anti-rejection drug cyclosporin will increase serum concentrations of both drugs. And if you use it with the fibrate, gemfibrozil, you'll increase the risk of gallstones. And therefore that drug combination is contraindicated. On the average, this drug is very well tolerated. It's oral, only available orally. Now, let me introduce you to some rather new drugs. If you have familial hypercholesterolemia, what? Why are you looking at me that way? Oh, you want to go out. Excuse me. Her Majesty wants out. That's the cat. Where are you? Yes, meow. Yes, Her Majesty is not to be denied. Okay, if you have familial hypercholesterolemia, and we talked about familial hypercholesterolemia before, these are individuals with a genetic disease that prevents them from handling cholesterol very well. So they have chronically high levels of serum cholesterol. So on page 66 of your notes, in fact, so page 66 of your notes, there's a table here of the different types of familial hypercholesterolemias. Again, these are inherited. They're due to genetic mutations in genes that encode components of the machinery that removes LDL from circulation. So some of these are due to mutations in the LDL receptor. So you can see type 2 familial hypercholesterolemia is due to LDL receptor defects. Others are due to mutations in ApoE. Others are due to mutations in ApoC2. Some of these are just unknown. Whatever the result, you get very, very high serum levels of LDL. Levels that are beyond, 250 or something like that. These people have LDL levels on the level of 400, 450, 500, 600, 700, 800 milligrams per deciliter. These people have very, very high LDL levels. They're in very high concentrations of statins, and then other types of drugs are also available as well. So if you have a familial hypercholesterolemia, you can also be treated with something called a PCSK9 inhibitor. A PCSK9 inhibitor. Now, what's PCSK9? PCSK9 is part of the machinery that helps deal with LDL. So here's the LDL receptor. It will bind to LDL. It will internalize the LDL into an endosome. It fuses with the lysosome and it gets degraded. The LDL receptor is recycled. But if PCSK9 binds to the LDL receptor, then the LDL receptor is marked for degradation. And now the LDL receptor is degraded in the lysosome, just like the LDL. So PCSK9 means you'll have decreased LDL receptors on the surface of the cell. PCSK9 inhibitors are monoclonal antibodies that bind to PCSK9, prevent it from binding to the LDL receptors, and increase the number of LDL receptors on the surface of cells, of hepatocytes, and therefore increase LDL removal from the bloodstream. So these drugs come in an injector pen that the patient injects subcutaneously. There's 2 of these drugs. There's alirocumab. And these drugs are shown on page 75 and 76 of your handout. Alirocumab, which is marketed under the name Praluent. And then evolocumab. Evolocumab is marketed under the trade name Repatha. These drugs will lower LDL substantially. So if you add it to a high-dose statin, they will lower LDL an additional 50 to 60%. There are 2 extensive clinical trials. There's the Odyssey clinical trial, and then the Fourier trial. Fourier trial looked at evolocumab. Odyssey outcomes looked at alirocumab. These not only decreased LDL, they showed significant decreases in hospitalizations, cardiovascular events, those being heart attacks, strokes, and the like, and mortality. In order to be approved to get these drugs by the insurance, you have to essentially have a LDL that is extremely high. But again, these come as injector pens, and they are injected usually once a month. The pens are usually single-use pens. You can get a pen whereby you inject yourself once every 2 weeks or just once a month. While these drugs are new, it's clear that they're well tolerated. Most of the side effects occur at the site of injection. So you'll get soreness and redness at the site of injection. You might get some mild muscle aches, rashes, or urticaria, otherwise known as hives. Here's a picture of one of these injectors. Here's another one down here. The downside is that these drugs are new, so they're really expensive. A single-use injector pen for evolocumab, $225. For alirocumab, $560. Multiply that by 12. That's the amount that it would cost you for a year. So these pups ain't cheap, shall we say. Are there any questions about any or all of that? Now, there are just a few more products that get advertised. They're not used a lot, but they get advertised a lot in magazines and television. And these are these polyunsaturated fatty acids. So over the counter, these would be your fish oils. So these are omega-3 fatty acids. There's an FDA-approved product for severe hypertriglyceridemia. So Lovaza is one of these. There's another. It's a icosapentol ethyl product called Vasepta. That was the second prescription of these approved by the FDA. And then the newest one is called Epinova. These are all very well tolerated. You get an unpleasant aftertaste, usually something kind of fishy tasting. That goes away, especially if you give these with liquids. Some people get a little sour stomach. That tends to go away. That's also not that common. And then burping and tasting the fish oil, but that goes away. Usually these are well tolerated. These will lower triglycerides. Fish oil, I think, is a good idea, except the clinical studies on fish oil and cardiovascular disease have been incredibly disappointing. Very, very large studies of people taking fish oil and comparing them with people who don't take fish oil have not shown a difference when it comes to either risk of cardiovascular incidents or mortality. However, it's very clear that the quality of fish oil differs wildly amongst the different fish oil products. So if you're going to take fish oil, and I am personally an advocate of fish oil because I think if you use high quality fish oil products, your fish oil products start having a lot better results. Also, fish oil has other benefits beyond cardiovascular benefits. Make sure you check out the quality of your products. And I am a big fan of Consumer Reports. So look at consumer reports and look at the quality of the fish oil. These are all prescription. So these are high quality. But if you want to take OTC fish oil, be very careful where you get your fish oil, because just some stuff that I did just off the cuff in the lab, I had a student trying to analyze fish oil, 3 different products from Meyer. And the amount of oxidation of those products was all over the place. Now there's a very, very new product. It's called bempedoic acid. This goes under the name of Nexletol. This is an inhibitor of citrate lyase. Citrate lyase. Why is this significant? Citrate is moved from the mitochondrion to the cytosol in order to make fatty acids. And the cytosol is degraded by citrate lyase. That's how you get the precursors to make fatty acids. This drug inhibits citrate lyase. So it's approved as an adjunct, not a monotherapy, to statins. And it'll drop LDL an additional 15 to 17%. So side effects include things like back pain, extremity pain. Some people show an increase in hepatic enzymes, indicative of some liver damage. You get increased uric acid concentrations, therefore this can exacerbate gout. There have also been reports of tendinitis. This is a very new drug. It's also combined with ezetimibe. That combination is called Nexlizet. That combo decreases LDL close to 40%. Bempedoic acid, very, 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 very new. And that is all I have to say about hypercholesterolemia. Are there questions about any or all of that? If not, then we will soldier on to coronary artery disease. So if you get blockage in the coronary arteries, you'll have decreased delivery of oxygen to the myocardium. And that will cause a mismatch, sometimes between myocardial oxygen demand and myocardial oxygen delivery. That will cause a condition called angina. Angina. So let's consider the blood supply to the heart. The blood supply to the heart. So to begin with, the coronary circulation is composed of coronary arteries and coronary veins. The arteries here are shown in red. The veins are shown in blue, which is keeping with common anatomical convention. Let's start with the coronary arteries. The coronary arteries branch essentially from the base of the aorta. So they originate in the so-called left sinus of Valsalva in the aortic root. The sinus of Valsalva would be right about here. So from that, you get a right and a left coronary artery. So you have there's your left, there's your right coronary arteries right there. Let's take a look at the left coronary artery here first. So the left coronary artery is going to move this way, and it's going to essentially sit in the so-called left coronary sulcus. The left coronary sulcus is a groove on the outer surface of the heart that marks the point of division between the ventricles and the atria. Some books call it the atrioventricular groove. There's a branch that then descends in this direction along the anterior interventricular sulcus. This branch is called the LAD, or the left descending artery. Left descending artery, the LAD. The LAD supplies the anterior 2/3 of the interventricular septum. It supplies the anterolateral papillary muscle and also the anterior surface of the left ventricle. So it supplies the anterior 2/3 of the interventricular septum, the anterolateral papillary muscle, and the anterior surface of the left ventricle. The next branch swings in this direction here. And this is the left circumflex artery. The left circumflex, otherwise known as the LCX. And it moves along the coronary sulcus. It moves around the left side of the heart. It's going to supply the left atrium and the posterior walls of the left ventricle. The left atrium and the posterior walls of the left ventricle. And if we go to the back of the heart, so here's the back of the heart here. There's a branch down this way. This is usually called the left marginal branch of the circumflex. Then there's a branch down here that's called the posterior left ventricular branch as well. But those are both branches of this circumflex. That's the main artery. And it supplies the left atrium and the posterior walls of the left ventricle. All right, let's go to the right coronary artery. So that originates from the right sinus of Valsalva of the aortic root, and it heads in the opposite direction. It follows the coronary sulcus as well. And it's going to send multiple branches to supply the right ventricular muscle, the first of which is right here. This branch here is called the right marginal branch. The right marginal branch. It is then going to swing around, swinging around here like this. And you're going to get this vessel that moves down like this. That is going to descend down the interventricular groove on the inferior surface of the heart. This is called the posterior descending. It's also called the posterior interventricular branch. So the PDA, the posterior descending branch. And the right coronary artery will supply the right ventricular outflow tract. It supplies the SA node, and it supplies the right atrium. It supplies the right ventricular outflow tract. It supplies the SA node, most of the time at least. And it supplies the right atrium. The posterior descending artery with other branches like the posterior lateral branch. These are going to supply the AV node. They'll also supply the inferior lateral walls of the left ventricle. And they'll also supply the posterior medial papillary muscle. Let's talk veins. Let's talk veins. Oh, one thing about this, there are variants of this circulation. So sometimes the PDA is supplied by the circumflex here, as you can see. Most of the time it's supplied by the right. This is called a right dominant circulation. That's the most common. Now, if it's supplied by the circumflex, that's called a left dominant circulation. Left dominant circulation. And if it's supplied by both, it's known as a codominant, and the codominant is the rarest of the three. Okay, let's talk veins now. Veins are going to return the waste products like carbon dioxide, stuff like that, from the myocardium to the lungs. These are going to move in the same capillary beds as the coronary arteries. And so just like their arterial counterparts, you have the so-called great cardiac vein. So this vein right here, this is the great cardiac vein. Here it's called the left coronary vein. It's also called the great cardiac vein. And then in the posterior interventricular sulcus, you have the, over here, This is the right, or sometimes called the small cardiac vein. Small cardiac vein right here. And then on the back side of the heart, the vein that runs parallel to the PDA, that's called the middle cardiac vein. And all three of these are going to empty into a big vessel called the coronary sinus. Yeah, that sun going across this makes this hard to see, but so the veins here come up, and there is this coronary sinus, and then the coronary sinus empties into the right atrium. That's the coronary sinus. It comes across here. It's in the coronary sulcus. That's your coronary sinus. Can you guys see that all right? Nobody's saying no, so I'll assume you can see that all right. All right. Now, if you have this mismatch between cardiac output, that is cardiac oxygen demand, and delivery of oxygen to the myocardium, you have angina. It is usually due to atherosclerosis, but it can also be due to hypertrophic cardiomyopathy. Where the myocardium enlarges because of aortic stenosis or hypertension. Angina comes from the Latin angere or angere, which means to strangle. And so it feels like a strangulation of the chest. The mismatch between myocardial oxygen demand and myocardium oxygen delivery creates a retrosternal chest discomfort. It feels like a pressure, a heaviness, a squeezing, even sometimes a burning or choking sensation in the chest. The pain is either localized in the chest. It may also be localized in the epigastrium, the upper stomach area. It can also radiate to the back, the neck, the jaw, or even the shoulders, in particular the right shoulders. This gentleman here, notice he has the fist over the chest. That's called a Levine sign, a Levine sign. If it's an open hand, it's a palm sign. That shows that there's pain. This is not the kind of pain you get when you did too many declines in the gym. This is a pain you have to grab onto something and steady yourself. It really hurts. The pain is precipitated by exertion or by eating a large meal, by exposure to cold or emotional stress. It lasts usually 3 to 5 minutes, and it's relieved by rest, or as we'll see, by nitroglycerin. The pain intensity does not change with respiration, does not change with a cough or a change in position. That's another characteristic of angina pectoris pain. This is different than a heart attack. In angina, you do not get the death of the myocardium. In a heart attack, you get death of myocardial cells. That's a difference between angina and a heart attack. They're different. Okay, we are out of time. And I will see you guys a week from today. You'll have a quiz, but it'll be online. And it'll be due, since Monday's a travel day. And some of you are probably going to be traveling. I'll probably make the quiz due Tuesday instead of Monday. Will that work? Yes, okay. I see one thumbs up. So you'll have a quiz, it'll be online. Instead of being due Monday, it'll be due Tuesday. All right. And don't forget, you can email me questions if you have questions. And please, all of you, have a very blessed Easter. He has risen. I will see you next week.
Thank you.
You're very welcome.